From Silent Seed from Israel.
Can you guide me here?
We can have
Forward.
Slide. No, it's coming.
So here? Left, right? Yeah, okay. Right. Thanks. Okay. Morning, everybody. Thank you, and thanks to the organizer for letting me presenting Silent Seed for you. This is a fairly young company, 5 years old, established in Israel. People here are advising us almost from day one. Half of them are also investor in the company. Professor Sela and Arnon developed the Copaxone. John Rossi is a leader in RNAi. Kabili developed the Kabili patents covering monoclonal antibody. Professor Bernards, from Doxil. Professor Dom from the brain tumor wafer called Gladial and others. And Pirak and Sela developed also the Erbitux. So we have quite a lot of knowledge covering us. So the company is developing a product that we call LODER, local drug eluter, and we have it designed now for pancreatic cancer. So the first product is called SIG12D LODER, and this is tested now and in clinical. We completed the first phase, and we are moving to phase 2, phase 3 early next year. We are covered by 7 families of patents, and our next and third project will be prostate cancer and glioblastoma. So all of these progression are based on our delivery and actually a combination between the delivery and the RNAi that we are using. Pancreatic cancer is really unmet need and is growing. There are more people dying from pancreatic cancer compared to prostate cancer, which is 10 times more prevalence. And for whatever reason, actually nobody really knows, the number of patients is growing very fast. What is a challenge? The challenge that we are facing is that solid tumors are permeable. It is very difficult, almost impossible to stream drugs to the tumor. And we are dealing with large tumors, not centimeter cube of mice, but as shown before, very large tumor, and they tend to be opaque. Pancreatic cancer tumors specifically, they are full of hyaluron N, collagen, fibroblasts, and the stroma is very opaque to drug diffusion. And this is, I think, 30 years old problem that still, I think, whatever kind of delivery is aiming to this tumor needs to solve. The diffusion is so slow that it can take theoretically 1 month compared to a few minutes in a normal tissue. The interstitial pressure in the core is 10 to 20 millimeter mercury up. So you have a gradient of pressure that actually push out drugs that will be streamed through the circulatory system. So even EPR works, and even you see drugs that are penetrating from the peripheral arteries, it's very difficult to stream them into the core. And in fact, it's kind of a paradox, because as long as you do more and more targeting, you actually make sure that the drugs or the nanoparticles that stream out from the artery actually will stuck in a very surrounding area, not in the core. So we decided that we take a strategy that we select the proper drug. Thank you. We select the proper delivery, but also we select a new kind of modality or a new kind of treatment, if you wish. And the target that we selected is KRAS. KRAS is a very well-known oncogene, appears about 30% in lung cancer, 40% in colon cancer, and more than 90% in pancreatic cancer. But so far, even it is a so well-known target, none of the efforts so far bring an actual drug. It sits intermembranal, but upstream to a few well-known pathways that leads to cell proliferation, cell survival. And if the where is it? Yeah, if the KRAS itself is mutated, then whatever monoclonal antibody you will block here, like Erbitux, the downstream signal will continue. So that's why 40% of the colorectal carcinoma patients are not taking advantage for the Erbitux. So it downstream signals very intensively, and because of the lack of drugs targeting the KRAS, there are many efforts. A few of them have managed to run to FDA-approved drug targeting the MEK. There are RAF inhibitor. There are, of course, rapamycin and else, mTOR inhibitors, AKT, PI3K, and others. And we managed to target the KRAS. And why we manage where others fail? Because we're using RNA interference. That's the nice thing with RNA interference. So our solution, as I said, is taking the RNA, developing a new delivery that I will elaborate with that we call LODER, local drug eluter, and develop a new modality. So what practically we are doing, we have a siRNA that it is targeting the most frequent mutation in pancreatic cancer. And you know, siRNA is a double-strand RNA, and we encompass these molecules in a millimeter scale biopolymeric matrix that we implant with a standard biopsy needle, endoscopic biopsy needle procedure that is today is really a standard for pancreatic cancer patient. We are implanting into the tumor. We, in fact, implanting four or today even 8 loaders. And as you can appreciate here, this loader is after 2 months in mice. You can see this is the hair of the mice here. And the area remain completely clean out of protein coverage or whatever things that will block the drug to stream out. And the holes are only 1 micron by radius, so meaning that this loader maintains the drug, preserves the drug in body 4 months. If it is siRNA, which is tend to degrade in a time scale of minutes in normal tissue, and on the other hand, can release the drug per what we are programming. So we can kind of programming the release using typical, playing of the excipients. We can release in a burst fashion. We can release in a zero mode linear fashion. We can release in a hibernation fashion, namely that most of the drug will be released later than, maybe very applicable to prostate cancer. If we take our siRNA and we conjugate with cholesterol, for example, that might change the release curve, so we can do, with playing with the excipients, also back to optimal release curve. And today we selected the release curve that after 2 weeks sheds between 50 to 60% to give the first impact and then to release most of the drug. We think that it is extremely important that the release period will be continuous. It will be much longer compared to the cell division time. And the cell division time is typically a day or 18 hours in pancreatic cancer. So what you want to do, you want to release 100 times more before the tumor grows. This is crucial. And in prostate cancer, the cell division time is 3 weeks. So that's why we are now engineering 2 years reloaders that will stream the drug continuously and efficiently along this time. Oops. Sorry. Okay. So, you know this. So let me wrap up and brief on the results that we did in preclinical. We showed in the message level, in the protein level, on the cell survival level. Later then we showed that indeed once we downregulate the KRAS, we downregulate downstream like the AKT and the ERK. And on the left one, you can see that we stain, and we see that specifically cells are affected. I mean, we stain to KRAS, and then we watch the propagation of the drug, and we realize that it is typically 1 millimeter a day. So after typically a week, the entire tumor is covered. And this is very interesting for those who are learning tumor behavior, because 1 millimeter today translates to 0.01 micrometer a second. This is a lower limit predicted 30 years ago by Rakesh Jain and others of convection in a very dense tumor. All these results been published recently on a PNAS paper. So we show that the tumor shrank, and we saw this kind of propagation after 4 days, 7 days, and 30 days. And then we saw also that the treating with KRAS also affect, or actually reverse, a transition called EMT. Namely, it has the potential to stop creation of new metastases, and we show it also on the gene expression level, and we show it also on the mice model when we treat locally with tumor, and then we follow the creation of metastasis, and none out of 9 mice develop metastasis when we treated them by our loader, compared to typically 50% that appear in other controls. So with this, we moved to phase 1, or actually phase 1/2 in pancreatic cancer. It was done in Israel in 3 centers. Typically, the adverse event was related to the chemotherapy that was supplied specifically for FOLFIRINOX in 1 patient, and another adverse event was related to this procedure. This is very common, but none of the adverse events, there were very few, but none of them been related to the drug. And the efficacy was indeed encouraging. I will want to elaborate, that's why, on the efficacy result. So first we show, we notice the tumor response. This is an example. You can see here that the tumor shrunk fantastically, and you can see it by watching the stent. This is a plastic stent. You can see the stent after 3 months get wider. So if you watch the long diameter and you compare it, as you know, between plus 20% to minus 30%, it is considered as a stable disease, and indeed all our patients were in a stable disease, or part of them actually showed some response after 2 months, and after 4 months, the same picture, even better, and after 6 months, the same picture, and even better. Because it was phase 1, we were not able to follow up all patients. We originally designed it only for 2 months, but all those that are not appear are on the level of stable. And if you watch the volumetric, it is even more impressive. This, for example, a lady has a very huge tumor which completely disappeared. We treated only single time. We did not treat second time after 4 months, so it was a single dosing, and unfortunately we were not able to continue this treatment. That's of course what we'll do next. We watch also the CA19-9 tumor marker, and it was reduced fantastically even before we provide the chemotherapy, which usually was a Gemzar, and later there was FOLFIRINOX. So most of our patients also show very nice decline in CA19-9 tumor marker. So we saw the tumor response, we saw the tumor marker decrease, and then, sorry about that. And then we watch the tendency of the survival. So what we can do, we can learn from recent locally advanced pancreatic cancer studies, as then you can see the progression-free survival, the time that patients show progress from local disease to metastatic disease is typically 5 to 6 months. the typical time for survival is 11 or 10, 11 months. And we are now on the 15 point something in the overall survival and 8.25 in the progression-free survival. So we definitely push the progression of the disease by a few months. And note that none of our patients die before 7.5 months. This is very important for us. And none of our patients progressed before 5 months. So that's actually mean if you see the level of the normal, that something, or it seems to be that something really happened in the treatment period, which was 4 or 5 months. And that's is very encouraging us. We are showing now that even later than on the time frame of 18 months, our curve looks much better compared to these studies, and 2 patients are still alive. So maybe even the 2 years survival will be even more fantastic. Note that in one study, all patients die after 18 months. So with this, we are going to phase 2. Maybe it will be recognized as phase 2, phase 3. It's going to be in Memorial Sloan Kettering, Johns Hopkins, MD Anderson, Gustav Roussy, Imperial College, and 4 locations in Israel. The primary will be overall survival. We decided to go to the most important endpoint because we really think that we are extending the overall survival of patients. We are moving next with prostate cancer. We are selecting targets. These are 2 targets that now we are selecting. And the same we see in mice model of prostate cancer that they are pretty the same effects. We are moving to next generation loaders that will stream nanoparticle. That's a nanoparticle part of my talk. To cover, for example, glioblastoma, to better diffuse the drug in a more diffused, still local, but diffused tumors. We are covered by 7 families of patents. And this is my last slide. We are encouraged partnering with us toward one of these progress or projects. Thank you very much.
Thank you very much. Well, it's also a very interesting talk about drug delivery, but in a bit different than before. So we have questions to this presentation directly. There's one.
Yeah, your talk was too impressive. And in your trial 1, did you look at the history of the patient? So did you try to score something? Are there 2 fibrotic pancreatic cancer or less fibrotic pancreatic cancer? What kind of patients did you choose for your phase 1 trial?
They selected
stage?
Only based on if they have a local disease, not based on pathology. So if they are defined as local disease, unoperable, non-resectable. This typically is 30% of the patients derived to the medical centers.
Did you modify your siRNA to enter into the cell? How do they enter into the cell? Did you make it positively charged, or did you modify them such that they enter into the cells?
Actually, excellent question. We knew when we started that siRNA penetrate to cells in tumors. This is a little bit shift from what you read in textbook, but it happens in tumors. And we are now studying 4 different reasons. So I'll just elaborate. I will not show results here. And the penetration efficiency is not high, but as mentioned here, we are streaming 10 to 8 molecules per cells, and if 1,000 of the molecules penetrate, that's more than enough. So there are at least four points that we're studying. One is the pH that makes the membrane a little bit more permeable. Second is a very close proximity between one cell and another cell. So the entire electrostatic potential that is minus 20 or minus 30 is diminished to unhealed. Thirdly, in rapid cell division, if it is something like 18 hours, the division is abnormal. I mean, the permeability of the membrane is abnormal. And lastly, these tumors are full of ammonia, bombarded by ammonia, estimated to be 2 to 5 millimolar. And it seems to be that there is an in situ complexation, and we're studying this. And by the way, we took ammonia, and it works better than whatever lipofectamine and transfect reagent that you are using in the laboratory. You just take ammonia plus ammonia chloride or something. So it seems that it might be relevant here. We are very aware about other results for famous companies, strong companies, that in tumors, specifically compact tumors, there is some level of few percent, and we showed it here in qPCR. There was one slide that I briefed on that.
Thank you.
There's a question.
Oh, it's a very nice talk, very impressive data. Congratulations to that. I have a question. If I correctly understood, your siRNA is targeting the mutated KRAS variant. Is that correct?
We are targeting KRAS. We are targeting one of the mutation of KRAS, but it's, yeah, it is a 12 codon. It's called G12D.
Okay. So have you tested also your siRNA on cells without the KRAS mutation, if there's also a toxic effect on these cells?
Well, this approach is completely different from what you see. We are actually will be happy if there will be some toxic effect. And we like to encourage interferon beta because it's local. There are many treatments that are aimed, not presented here, but they are aimed to encourage interferon beta within the solid tumors. Bear in mind that we are streaming 3 meg, only 3 meg along 4 months. So all these tox issues that are elaborated here on systemic delivery are not so bothering us. The typical single injection is, say, 100 meg or something like this in systemic delivery. We are streaming 3 meg along 4 months. Okay. No issue.
I was more thinking about if your patients have now this KRAS mutation, right?
Yeah.
Have you screened them for that? I think you have, right?
If they have cross mutation? That was the question?
No. It's I'm wondering if your siRNA is specific for this KRAS mutation. I'm thinking about personalized therapies, because, I mean, only patients with the mutation would respond to the treatment, right?
Yes, but there are, in pancreatic cancer, 90% of the patients have.
Really great.
Yes, and if you want to elaborate, 90% have the mutation. In this 90%, 50 are G12D, but the 30 less are G12V. And it's the same codon, so practically it works also there. The RNA. The RNA is not that specific.
Okay, thank you.
Yeah, that's why, by the way, we selected pancreatic cancer. In glioblastoma, you have a single mutation that is covered more than 10%. So it's very difficult. The mechanism needs to be there. Some other solution.
Yeah, I was thinking about the BRAF mutation in melanoma, which is only 5% of
we are
the
not,
patients, right?
You see, BRAF is downstream.
Yeah. But as I said, you have a big patient group, which is a big benefit for you. In comparison to the BRAF mutation, only in 5% of the patients, you have a really nice and broad application range.
Yeah, and it affects also pathways that go to the icadrine, for example. It's really interesting how strong is KRAS as a point of kind of junction, node of junction.
Thank you.
Okay. Yeah, there's let me see a last question. Yes, Steve? Oh. Yeah, but still one day. At the end, you have again a discussion. But there's another question.
Yes, thank you.
Hi, you mentioned that you weren't putting any delivery agent in your pancreatic system, and the penetration efficiency of the siRNA was low. When you move to your prostate system, where the doubling time is longer, do you need to add a delivery agent?
Well, we will see. We practically used 14 modification and conjugation. I mentioned cholesterol, what we did, and we're back to a basic SI. Because, as mentioned before, sometimes when you improve the delivery, you pay later then. Penetrating peptides, for example, it is now known that even the efficiency to enter to the endosome is very high. It's only 1% typically available to RNAi. So if you manage to stream the drug on a low level, but to the cytoplasma anyway, then it is available. So it's multi-steps. So whenever you play with whatever kind of nanoparticle conjugation, you pay somewhere else. In prostate, what really bothers us is the distribution of the drug, because it's more infiltrated and it is not that compact. So once we bring something very close to the cells of the malignant cells of the prostate cancer, and by the way, specifically to the stem cells of the prostate cancer, then, as I said, if it will be 10 to 8 or 10 to something, very high molecules, and only 100, 1,000, 10,000 will penetrate, that's enough. So the efficiency of the penetration could be less than 1 promille, and it is still effective. This is a completely different play.